My name is Amy Pruitt from the University of Pennsylvania. Today I'm going to be discussing neurological aspects of systemic cancer. We will discuss diagnostic and management dilemmas of increasing concern to neurologists in the both inpatient and outpatient settings. The plan for our talk will include a number of issues. Sorry, I forgot that. Can you erase all of that? I forgot the disclosures. So let's go back. I'm sorry. Yeah, let's just start over again. I definitely meant to do that. All right, sorry. Okay. My name is Amy Pruitt. I'm going to be discussing neurological aspects of systemic cancer. We're going to be covering diagnostic and management dilemmas that are of increasing concern to neurologists in both the inpatient and outpatient settings. I have a couple of disclosures. The first is that many of the treatments we will be discussing are not FDA approved or supported by Class 1 studies, but American Academy of Neurology evidence guidelines will be respected and cited where appropriate. And I have another more personal disclosure, which is that I believe that neurologists play a role as primary care physicians in the management of these complicated patients throughout their illnesses. The patients have oncologists, neurosurgeons, radiation oncologists, physical therapists, and all sorts of other physicians, but they need someone to manage both the diagnostic and ultimately the end-stage care of these very complicated problems. Who better than a neurologist to play that role? The lecture plan is as follows. We'll spend some time on that most common of complications, cerebral metastases, emphasizing lung cancers, breast cancers, and melanoma. We will also talk about the very difficult to treat carcinomatous meningitis and what might be new on that front. Epidural cord compression will be covered, though nothing is particularly new in that realm. And we will talk about the increasing numbers of complications of therapies, such as radiation therapy, chemotherapy, and their associated infections. We'll branch out into new toxicities of some of the newer biologic agents, new patterns of toxicity, new timings of toxicity, and indeed new diseases. Finally, we will end with supportive care during and after cancer therapy, emphasizing seizures, cerebral edema, thromboembolism, and finally, a very important role for neurologists in the evolving subspecialty of palliative care. Let's begin with brain metastases. These are the most common intracranial neoplasms in adults, and there are up to 200,000 cases per year. Up to 30% of patients with cancer will have brain involvement. Lung cancer patients represent the largest absolute numbers, and melanoma, the highest propensity to spread to the brain, accounts for a smaller but devastating number of patients. The distribution reflects cerebral volume, thus most are supratentorial lesions. They occur in watershed areas and at gray-white junction. About 10% of these metastases present with hemorrhage, and the overrepresented in this group are melanoma, renal cell cancers, thyroid, and choriocarcinoma. There have been two sections on cerebral metastases in recent issues of Continuum, the neurologic CME publication from the American Academy of Neurology. How did the two articles from 2012 and this very month in 2015 differ? And one of the prominent features I found in the difference between these two articles is that quality of life issues after adjuvant whole brain radiation therapy became of increasing concern, and people were emphasizing that patients may live a bit longer, but they have a decrement in their quality of life after whole brain radiation therapy. This is a theme to which we'll return. Patterns of care and survival with brain metastases have been analyzed in over 100 patients in two different time intervals. The first is from about 30 years ago, and the other much more recently. These include both U.S. and European sites. Probably the biggest differences are explained by the increasing prevalence of women in the more recent group. And you would think this was possibly from breast cancer, but unfortunately, it's an increase in women with cerebral metastases due to lung cancer, 56% of patients versus 11% of patients some years ago. Women are twice as likely as men to have CNS metastases from lung cancer, a demographic feature that has not really been explained. Other differences between the two periods are that solitary metastases were found more often in the 1980s, perhaps again because of sensitivity of MRI scans, and there were fewer extracranial metastases at the time of diagnosis some 30 years ago. So we're doing better controlling the systemic disease, and with that there is a change in the demographics of cerebral metastases. They can present in many different ways, and the neurologic consultant needs to be there to help the team decide whether palliative radiation therapy alone is the best idea, whether gamma knife surgery or cyber knife surgery is important, or whether the patient ought to have surgery altogether. So let's look at 3 people on this slide, and we'll look at some other presentations in a moment. On the left is someone who is presenting synchronously with his lung cancer, in this instance a non-small cell lung cancer, whose first symptom was a seizure, and therefore he was found to have cerebral metastases, all supratentorial at the time of his original disease. He's going to do well with palliative radiation therapy. The second patient is not going to. She has well-controlled ovarian cancer, albeit with some known systemic disease. But as you can see from the location of the lesion in the upper middle MRI here, she's not going to get through radiation therapy if she blocks off her 4th ventricle and has obstructive hydrocephalus. She needs surgery for this in order to have good palliation. She might even have this lesion resected at the same time. And some of you may say, but isn't the presence of cerebral metastases the life-limiting part of the illness? And indeed it is not. This is something you should emphasize to all of your medical colleagues, that 2/3 of patients who have cerebral metastases will succumb to the progression of their systemic disease and not to their cerebral disease. The third patient represents a different reason for a surgical requirement. And this patient has a lesion that looks for all the world like a pituitary neoplasm. It was thought, in fact, to be a pituitary macroadenoma that presented with headache relieved by getting up early in the morning. When he got some early morning hydrocortisone and his prolactin level was improved, he seemed to get better, but then it began to grow, and he was known to have renal cell cancer, was receiving sunitinib at the time with improving systemic disease, and finally had to biopsy to prove that this, in fact, was a metastasis from his renal cell cancer. Unusual appearances may confound the neurologic consultant. The first patient is a patient who was thought to have, in fact, parasitic disease. She was 5 years out from a mastectomy. She'd received radiation therapy and had a personal history of raw meat consumption, making the diagnosis of toxoplasmosis of these very large lesions with punctate calcifications and very little surrounding edema, possibly due to parasitic disease. However, she was also found to have new pulmonary and bone metastases, and a biopsy of these showed that, in fact, they were metastases from breast cancer. The other patient on the right has an even more difficult dilemma. She was referred as a possible case of carcinomatous meningitis, but look carefully at the enhancement pattern. There's smooth dural enhancement, and this patient was found to have calvarial metastases. She had benign CSF with a minimal increase in protein, and this is in fact a venous congestion problem due to the adjacent calvarial metastases. It's not low intracranial pressure, and it's not carcinomatous meningitis. Other unusual appearances include this patient who presented with TIA-like episodes in the setting of known squamous cell carcinoma. As you can see from the upper slides, there is on the coronal a rather diffuse pattern of contrast enhancement, seen better in the white matter and in the caudate here. It's seen at really all levels, including in the temporal lobes and in the posterior fossa. This is miliary metastases, another known pattern, but one that can cause some diagnostic confusion. Other areas that can cause diagnostic confusion are when the metastasis spreads from the calvarium through the dura and into either one of the sinuses or into the parenchymal itself. Think about where the dural metastases are with respect to the blood-brain barrier. In fact, they're outside the blood-brain barrier, and it's your job to say maybe these might be amenable to chemotherapy, unlike those that are in the parenchyma itself. This patient presented with a left-sided leg seizure and had a marked increase in her symptoms over 3 months. She had a very good response to chemotherapy. Dural lesions in and of themselves represent an extensive differential diagnosis. They can include such things as meningioma, which is usually the entering diagnosis when the patient comes in for therapy. Lymphoma is another concern, a durally based lymphoma. Metastases that tend to go to the dura are those that are listed in parentheses here, and we're going to dwell on a couple of these in a moment. Remember the patient also who had a reactive reaction to calvarial metastases. Sarcoidosis is in the differential, nephrogenic systemic fibrosis, and then some very uncommon entities that may not be as important in the setting of known cancer. Importantly, a lot of these are steroid responsive. So let's look at the 4 slides over here. Here's a patient with prostate cancer. This lesion was actually entirely resected from the meninges. There were multiple nodules. Prostate, as you may know, tends not to go to brain parenchyma. It is producing some mass effect with the adjacent parenchymal disease, but it doesn't tend to go to invade the parenchyma itself. This patient was thought to have a meningioma, and that's not a bad imitation of one, but it was sarcoidosis. This patient, too, was thought to have a meningioma. And in fact, it's a durally based lymphoma. This is important to recognize because this is a very indolent, treatable entity, unlike its B-cell counterpart in the parenchyma. And finally, here is one really to recognize on the hematology surface. This is a patient who has extramedullary development of nodularity, and this is CML patient who has literally a chloroma that's growing along, again, doing a pretty good imitation of a meningioma here. Let's look at another such case. Here's a 24-year-old woman who is not known to have recurrent leukemia. She underwent an allogeneic bone marrow transplant some time ago for acute myelogenous leukemia. She is not known to have any hematologic or marrow recurrence, but presents with 2 months of progressive knee, thigh, and hip pain, and her examination was consistent with either a femoral neuropathy or an L3-4 lesion. Here you see on this sagittal T2 image, there's a large mass here, seen very well on these 2 axial views. And this is what is now known as myeloid sarcoma. It can present with acute myelogenous leukemia before, after, or during treatment. It's quite uncommon, but it's something very important to recognize in this group of people as it dramatically alters therapy. So how do you work up the more common dilemma when you see a patient with an isolated ring-enhancing lesion who has no known systemic tumor? And this is one of the most common sources of consultation on the inpatient service. So here's a 49-year-old smoker with paresthesias in her left arm. The differential diagnosis would include primary or secondary neoplasm, and it could include either immunocompromised or opportunistic or conventional infections. So what's a cost-effective workup here? A general rule of thumb is don't call a neurosurgeon first. Do at least something and think about the demographics of the cerebral metastases. As we mentioned, there are almost 200,000 new cases of intracranial metastases per year in this country. About half overall will be lung cancer. So that's a good place to look, particularly in a smoker. As you can see, the rate of spread is very high for small cell lung cancer and somewhat lower for non-small cell lung cancer. Other tumors are possible, but very much less likely if the patient is not known to have systemic disease. So the 2 places to look, the 2 types of metastases that can spread to the brain early on before the patient is known to have cancer are the various types of lung cancer and melanoma. So do a chest CT, look at her skin, and then call the neurosurgeon. This was an adenocarcinoma biopsied with a stereotactic biopsy consistent with a lung primary. Here's another patient with a rather different dilemma. He's 62 years old and presents with a week of gait trouble. He has no known systemic tumor, but he has multiple lesions, one of those few instances in which you sort of hope he has HIV, and this is toxoplasmosis. Not so. He had a widened mediastinum, and a bronchoscopy showed that he had small cell lung cancer. Unfortunately, his prognosis is very much worse than the patient we just saw with the isolated lung lesion. He, for one, has multiple lesions. For another, they're located in the posterior fossa, and despite the use of steroids, he stands a very good chance of swelling and being unable to get through radiation therapy because of lysis of the cells and raised intracranial pressure. A graded prognostic assessment scoring system allows the physician to look at this patient and give some idea of how likely he is to have a median survival of X number of months. The scoring system goes as such. 1 point is for a good Aronofsky Performance Status Scale and a young age with no presence of intracranial disease and 1 metastatic lesion. Our patient was closest to this. The second patient, on the other hand, had a poor performance status, age over 60, and the presence of extracranial disease as well. So unfortunately, his median survival is likely to be much less. This is pretty useful for all types of histologies, with the exception of melanoma because it's so radioresistant, which we'll get to in a moment. So in general, the treatment of cerebral metastases should include surgery for solitary metastases, a consideration of whole brain radiation therapy, which controls local disease, but at least in the short term reduces quality of life in patients who experience short-term and executive cognitive problems. So it's something to discuss up front with patients and their families. Stereotactic radiosurgery for up to 5 lesions. There has been a question as to whether the use of stereotactic radiosurgery increases the risk of leptomeningeal spread and subsequent carcinomatous meningitis. Recent data from my institution, the University of Pennsylvania, suggest that this is not likely and should not preclude a decision to use stereotactic radiosurgery. Radiation therapy clearly for more than that number of multiple metastases. And I've highlighted in yellow the evolving role of chemotherapy as an option. It used to be said a few years ago that there really wasn't any reason to consider chemotherapy for cerebral metastases because there was a blood-brain barrier access problem and the lesions were not going to respond. I've highlighted a few instances in which that is absolutely untrue. In the lung cancers, erlotinib and gefitinib have been very helpful in certain patients with specific types of lung cancer mutations, particularly in women who are never smokers. These drugs are highly metabolized, their metabolism is highly induced by the enzyme-inducing antiepileptic drugs, to which we'll return later. So being on Dilantin or carbamazepine is not a good idea for people receiving these drugs. Breast cancer patients may respond to some of the same drugs to which their tumors respond systemically. This would include capecitabine and lapatinib, the reference is there, and sorafenib for renal cell cancer. What about melanoma? Here is the cancer with the highest rate of spread to the central nervous system. And when it does so, it really is a life and quality of life limiting part of the patient's illness. In the last 4 years, we are beginning to replicate some of the modest successes that have occurred systemically with melanoma with the 4 drugs that are listed there: ipilimumab, fotomustine, vemurafenib, and dabrafenib, which will be discussed in a moment. So it is true that most patients with cerebral metastases succumb to their systemic disease. It historically has not been true for melanoma, and you see on the left there a classic situation in which a patient is known to have some axillary recurrence of melanoma, but then presents with multiple lesions, most of them hemorrhagic, as you can see on the center susceptibility study. And this patient really has no therapeutic options, in my opinion. We'll talk about some of the things that are evolving in a moment. On the right is the patient we met earlier with prostate cancer, and while that looks like a very large volume of metastatic disease, that's resectable. So always consider surgery as an option for these patients. So let's highlight a couple of special considerations in the 3 histologies that I mentioned earlier. Breast cancer may now have increasingly the brain as a first site of relapse. It also is one of the tumors with the highest rate of spread to the meninges, and the women who are most likely to have this are younger women who have HER2-positive breast cancer. We'll talk about lung cancers and melanoma. Occult metastases occur in almost 15% of young women screened for clinical trials with breast cancer. The risk factors are a young age, estrogen and progesterone receptor negative tumors, systemically LDH levels are elevated, positive nodes, and lung metastases. HER2 overexpression is another risk factor. However, chemotherapy can help more than 1/4 of these patients, and I mentioned the 2 drugs most in use a moment ago. When the tumor spreads to the brain, one does have to worry in these breast cancer patients about CNS metastases spreading to the meninges. This is the most common solid tumor with meningeal spread. 20 to 30% of advanced breast cancer patients have CNS metastases. And let's look at what happened to one of them. Here's a 49-year-old woman with an isolated CNS relapse 2 years after removal of a breast cancer with lumpectomy. She has HER2-positive cancer. She has a craniotomy, radiation therapy, and she received at the time bevacizumab, which temporarily was approved by the FDA for use in breast cancer, but was taken away from that indication in November of 2011, as indicated in the slide. Here's her original tumor, looks pretty conventional with vasogenic edema around it. But then she has a more diffuse infiltrating recurrence. And with that, she has a very worrisome set of findings. She has enlarging symmetric ventricles with signal abnormality around them, suggesting transependymal spread of fluid. These are very worrisome markers for carcinomatous meningitis. And indeed, if you look closely at number 4 in the lower right-hand corner, there's beginning to be some suggestion of leptomeningeal enhancement. What can we do for these patients? We can make a diagnosis, which is usually done with 2 or 3 lumbar punctures, which allows almost a 90% chance of finding this. You can use cytomorphology as well as flow studies. There has been a brief study looking at vascular endothelial growth factor as a sensitive and specific marker for carcinomatous meningitis, but that this has not been approved yet. Look at the overall survivals here. They're pretty dismal, but when HER2-positive cancers are treated with Trastuzumab treatment, so an anti-HER2 antibody, there's a dramatic improvement in survival and 1-year survival of over 60%. So beginning to make a little headway in this cancer, certainly something for neurologic consultants to know about. Let's look at another dilemma. Here's a patient with inoperable non-small cell lung cancer. About 10% will present at initial presentation with this and up to 50% at post-mortem. As you can see in the first 3 slides, he has some pretty difficult areas, deep in the thalamus, deep in the posterior fossa adjacent to the 4th ventricle, probably in the motor strip in the lower range, and a cystic lesion in the thalamus on the gadolinium study. So what can he have as first-line treatment other than radiation therapy, which again, because of the location of these, may not go very well? He could possibly have chemotherapy, and there are emerging options for cerebral metastases with pemetrexed and cisplatin in this group. Again, something for the neurologist to be aware of so that he just doesn't say the only treatment is radiation therapy. Here's an example of systemic and CNS metastases responding beautifully to erlotinib. In panel A on the left-hand side, there are miliary metastases infratentorially, and there's a very large lesion in the lung. On the right-hand side in A, you can see that really there's near disappearance of these lesions after erlotinib. And again, don't put your patients on dilantin. The erlotinib won't work because the dilantin will increase its metabolism. There was also a systemic response here. What about melanoma? There have begun to appear some isolated case reports of improvement. In the upper left-hand corner, the Roche article from the New England Journal shows a 16-year-old girl who has a dramatic response to multiple metastases to vemurafenib. This is an oral BRAF inhibitor. It is good for V600 mutated tumors. Radiographic responses were seen in 75% of patients, which is extraordinary for melanoma, with a complete response in nearly a quarter. 6-month survival was 92%, with 3/4 having good local control, and those are very dramatic data for melanoma. There is another small series listed on the bottom in panels A through H, and again, as you can see from the arrows in the upper panel, there are a great many metastatic lesions. They are much better. Again, hopefully, we are beginning to recapitulate the successes of systemic melanoma therapy. Dabrafenib is another drug that's in trial, and dual therapies increasingly are being considered for our melanoma patients. There are some toxicities of which you should be aware as you see more and more of these patients on the consult service. there was a question as to whether there would be an increase in the known skin toxicity of these drugs when patients were receiving concurrent cranial radiation. Turns out that's not true. And so that's established in a good clinical trial. And vemurafenib for brain metastases is part of another national clinical trial at this point. What I'm showing you in the lower right-hand corner is a rather dramatic skin reaction called cutis verticus gyrata. There are many dermatologic adverse events with the RAF kinase inhibitors, and vemurafenib and dabrafenib fall into this category. Rash, photosensitivity, alopecia, and a hyperproliferative cutaneous eruption like this one can be very dramatic. Ipilimumab is another drug that is used for melanoma. It's an anti-CTLA-4 antibody. You should be aware of its immune-related adverse effects as well. These can include sarcoid-like reactions, including uveitis and episcleritis. There are some systemic reactions that are listed there. But from the neurologist's standpoint, it's hypothyroidism, hypophysitis, and hyponatremia that are big problems centrally. There can be bilateral optic neuritis, as seen in this picture here. And there can be some peripheral problems as well, including a multifocal radiculoneuropathy, reference under the Manasukas reference here, CIDP, Guillain-Barré syndrome, myositis, transverse myelitis, and myasthenia gravis. When do these occur? Usually within 1 to 2 weeks of the use of the drug, withholding the drug, and treating with steroids and IVIG is the current recommendation. Again, something of which neurologists should be aware. While we are not always the quality of life limiting factor for a patient with systemic cancer, sometimes they are. Sometimes cerebral metastases are, and we are the people who come back to try to make the decisions about what to do in these difficult situations. Here is a patient with lung cancer who's 12 months out from radiation therapy. He had rapid recurrence with complicating features being these massive cerebral flare abnormalities. And what are we going to do for this patient? Really, barring better chemotherapy, there aren't any good systemic options for this patient. Reirradiation or surgery, sadly, are really not an option for this patient. Look carefully at the pattern of metastases comparing this patient to the patient in the previous slide, and you can see really that this is not parenchymal metastatic disease. I draw your attention both to the pattern of flare, which isn't very helpful, and to the pattern of contrast enhancement, which is in fact periventricular or ependymal. You can see it well in this coronal view here. And you can see that the patient is having enlarging ventricles and is going to require shunting. So these were cerebral metastases resected, followed by whole brain radiation therapy, and this is meningeal relapse. Greater than 2-year survival is seen in a few patients. Sadly, most of these patients are going to have some cognitive abnormalities. This patient received surgery, radiation, and then stereotactic re-irradiation. He's chronically required steroids, as you can see from his large amounts of flare abnormality, and these have been complicated by a myopathy. When CNS disease becomes the quality of life limiting factor while the rest of the disease is under control, that is probably the most difficult dilemma for the neurologist. This patient has had an excellent response of radiation for cerebral metastases, but you can see that the clinical correlate of all that flare abnormality on the left is likely going to be cognitive difficulty. On the right is a patient who received radiation therapy and has had no recurrence of disease, but this diffusion-weighted image shows a stroke in just the wrong place in the internal capsule with a devastating hemiparesis. Radiation therapy complications have long been described. It's only been recently that there's been much public discussion about a different type of complication, and that's chemotherapy. As one of our colleagues said, is the brain the new bone marrow? We don't have growth factors for the brain like we do for the blood. And is the chemo brain and other sorts of complications of chemotherapy going to be the quantity of chemotherapy limiting factor for these patients? I referenced 2 articles here. On the left is a comparison of women with breast cancer and chemotherapy, and a nearly equal number of women with breast cancer who did not have chemotherapy, and some demographically matched controls. This is a study that looked to objectify what women with breast cancer have been saying for years, which is that after chemotherapy, they're just not themselves. They feel fuzzy. They feel like they can't remember things. They can't multitask. And indeed, there was decreased activity on metabolic studies in the left middle dorsolateral prefrontal cortex in the first two groups, irrespective of treatment history. There was decreased processing speed and other abnormalities in the chemo group only, and that correlated with their subjective executive dysfunction complaints. On the right was a little bit different study. They looked at 196 survivors of breast cancer receiving what then was the standard of care, CMF, an average of 21 years earlier. So these people are 2 decades out from their treatment. They compared them with a large number of non-cancer patients. So I actually think probably a better control group would have been like the second group in the left-hand column, some women who had had breast cancer but who had not received chemotherapy. Predictably, the group receiving chemotherapy for breast cancer had decreased processing speed and subtle, not clearly quality of life limiting deficits by neuropsychologic parameters. Oddly, there was more depression in the control group. A few other studies have come out recently looking at MRI markers of cerebral small vessel disease in a large number of Dutch breast cancer survivors, published recently in Lancet Neurology. The average interval since treatment here was again more than 2 decades. These cancer survivors had higher prevalence of deep and infratentorial cerebral microbleeds, and poor cognitive function, verbal memory, and processing correlated, in fact, with the numbers of not so much the brain volume and infarction, but the numbers of these small cerebral microbleeds. We'll return to see some of these complications in a moment in different settings. Treatment of cognitive decline has not received perhaps enough attention. I should call your attention to 2 articles. The first by Shaw and others is probably the most quoted. These are 24 patients. Most actually had low-grade glioma and were many weeks out or many years out from their treatment. They received 24 weeks of donepezil, and they had improved health-related quality of life, improved attention, and verbal memory. These were modest gains, but important to the patients. A subsequent study by Rapp and colleagues looked at a randomized controlled trial of donepezil in 198 brain tumor survivors. A third of these were cerebral metastases, and all were more than 6 months out from their radiation treatment. They used the Shaw donepezil regimen also and noted, unfortunately, no difference at 24 weeks. Other choices are symptomatic treatment with methylphenidate and modafinil. It would be much better to prevent these long-term negative cognitive outcomes. And the one study that actually has been latched onto by radiation oncologists all across the country, though it's a small study that actually terminated fairly early because compliance with the protocol led to only 35% statistical power, is this study by Brown and colleagues. They looked at 508 adult brain metastases patients randomized to 24 weeks of placebo or memantine within 3 days of initial radiation therapy. Assessments were made at the intervals listed there with the Hopkins Verbal Learning Test. Only 149 patients were analyzable at 24 weeks, and the probability of cognitive decline by these tests was nearly 65% in the placebo group, 53.8% in the memantine group, representing a 17% reduced relative risk. What we need from this study is long-term follow-up for durability of this admittedly rather modest response. Nevertheless, I would bet that in many of your institutions, the radiation oncologists have moved to using memantine in this protocol, probably because we don't have anything else and this is such a desperately needed area. Are there less toxic therapies? This is a look into the brain of a patient who's receiving intraocular vascular endothelial growth factor antibody. He has proliferative diabetic retinopathy, and goodness, look at the difference between panel A and panel B. There is a dramatic regression in the right-hand picture. Just a week later, and visual acuity improved dramatically with it. What if we could do that to tumor vasculature? Well, for the last decade, people have been thinking about how to combine vascular endothelial growth factor drugs with cytotoxic agents, and they have led both to some dramatic successes and to some new complications of which neurologists should be aware. The intratumoral hemorrhage risk was initially a concern. This turns out to be a relatively low risk. A relatively higher risk is the induction of hypertension and the presence of PRES, accompanied sometimes by proteinuria. PRES is the acronym posterior reversible encephalopathy syndrome. There's a low rate of venous infarction and a roughly double the risk of a non-bevacizumab treated group of arterial thromboembolism or stroke. Patients should not have surgery within 30 days of receiving this drug or receive the drug within 30 days of surgery. Bowel perforations have been reported. Wound dehiscence is a problem for our surgical colleagues. Rebound edema is a problem for us, and once the patient has started on bevacizumab, he may be able to reduce his steroid requirement, but will need more when the patient comes off the drug. In brain tumor patients only, a bevacizumab-reported optic neuropathy has been noted. There are some other instances of hypothyroidism, and certainly the financial toxicity of this drug is huge. It comes in at around $9,000 per dose. In primary brain tumor patients, it's likely to give a 4-month increase in survival. More on this drug will take place in the section on primary brain tumors. Bevacizumab-treated lung cancer, like bevacizumab-treated primary cancer, has begun to show new patterns of metastatic recurrence. This is a patient who was treated very well for lung cancer, but when he developed cerebral metastases, they were very hard to recognize. You've seen this pattern in another squamous cell cancer patient earlier. They have multiple miliary metastases. The tumor co-opts normal blood vessels and spreads with a very aggressive phenotype throughout the brain, so one has to look carefully for these. Some of these patients will also develop carcinomatous meningitis. Fortunately, it's only about 5% of cancer patients because this remains a very difficult area for treatment. This is a series from Memorial Sloan Kettering. The histologies were the predictable ones. Breast and lung were the vast majority, with gastrointestinal malignancies, melanoma, and lymphoma and leukemia representing most of the rest. About half were diagnosed by imaging, and we've previously gone over the imaging characteristics of carcinomatous meningitis. About a quarter by a cytology, 80% by the second LP. The dictum is usually to do 3 LPs, and several were diagnosed by both methods. About a fifth of these patients received supportive care only by design because they were too ill to undergo any other treatment. Median survival for the group as a whole was 2.4 months, much less than that for some of the other solid tumors, and for hematologic malignancies, still not a very good survival at 4.6 months. Again, just to review the MRI presentation, when should you be suspicious? Here's a patient who presented with esophageal cancer. She presented with leg weakness and paresthesias and actually initially carried a diagnosis of diabetic neuropathy and Guillain-Barré syndrome, but there was rapid evolution both of her symptoms and of the signs on her MRI scan. So here are her ventricles when her legs were beginning to experience paresthesias, and here they are as they enlarge with vasogenic edema around them. Again, this transependymal spread. The temporal horns are very large. Here is a gadolinium enhanced scan. There's not much ependymal enhancement, but there's diffuse leptomeningeal enhancement along the spinal cord, in the posterior fossa, and in the 4th ventricle. So this is carcinomatous meningitis from a GI primary. Look carefully at some other histologies when you're thinking about whether this is parenchymal disease or carcinomatous meningitis. This is multiple myeloma, and these are multiple lesions that are actually carcinomatous, and they're masquerading as parenchymal mets here. Some of these patients are hyperviscous and can present with this picture, which is a venous retinopathy and a central retinal vein occlusion. Carcinomatous meningitis traditionally presents with headache, leg pain, and the clinical signs of papilledema, often with a 6th nerve palsy representing increased intracranial pressure. It spreads from brain metastases, as we've just seen, the choroid plexus, dura, vertebral bodies, or retrograde through peripheral or cranial nerves. There is therefore a predilection for the posterior fossa and, for gravitational reasons, the cauda equina, as illustrated here in this patient with diffuse leptomeningeal melanoma and very striking studying of the cauda equina nerve roots with nodular disease. The treatment is site-specific radiation therapy to the macronodular disease. You could consider with the facility that has such things proton beam to reduce the adverse gastrointestinal effects. It's much better focused and there are far fewer intestinal toxicities. Intrathecal therapy includes only a few drugs. The ones that have been practical are listed there. Cytarabine, depocytarabine, is given every couple of weeks. If this patient does not receive dexamethasone with this drug, he can have a terrible lymphocytic meningitis reaction with headache and nausea, so please be on board to prevent patients from having this on the oncology service. Another good trick management-wise is palliation for raised intracranial pressure, and this includes the use of the carbonic anhydrase inhibitor acetazolamide. This can be very effective for patients who are having pressure waves and with it brownouts of vision, headache, and nausea. Epidural cord compression also occurs in about 5% of cancer patients. Be very suspicious of back pain in the cancer patient and image early and often. This is a medical emergency. If the patient is going to regain ambulation, it needs to be treated with high doses of corticosteroids and emergency radiation or surgery depending on the histology, age, radiosensitivity, and rapidity of progression. People who are most likely to have a surgical advantage are those who are less than 65 years old, ambulatory, have fewer than 48 hours of symptoms, no compression fracture, or patients who can have a vertebrectomy and a fusion. This is a 50-year-old woman with breast cancer, back pain, and 3 days of leg weakness with an epidural cord compression. Having covered the demographics and common complications, we're going to talk about treatment complications now in the orders listed there. The standard classification of radiation therapy is acute, meaning during or immediately after the radiation therapy. This often takes the form of encephalopathy or the somnolence syndrome, which is more common in children. The treatment is with steroids, and it usually is temporary. Temporary also, and also treated with steroids, is the subacute radiation therapy injury, which occurs 1 to 6 months after radiation and is associated with demyelination. This can occur in both the brain and the spine, and these patients can have Lhermitte's phenomenon. And finally, the really difficult ones are the late, more than 6 months after radiation therapy, with delayed focal necrosis, atrophy, dementia, optic neuropathy, motor neuronopathy, plexopathy, stroke, and radiation-induced tumors. The patient who's listed here has a renal cell cancer and has radiation-induced myelitis. It was thought to be a recurrence of her tumor, but in fact she responded to one of the treatments that we're about to discuss. This is a patient who had a tonsillar tumor. In the radiation field was his temporal lobe on the left-hand side. He presents with a large amount of vasogenic edema and a ring-enhancing lesion 3 years after this squamous cell cancer, and this biopsy and partial resection shows radiation necrosis. People used to get anticoagulated for this. I think that's been very much out of favor. Hyperbaric oxygen treatment is tried, also not profoundly effective. And the latest entry into the field for treating this very difficult situation is Bevacizumab treatment. Again, vascular endothelial growth factors. The references for are listed there. Post-radiation myelitis, as well as intracranial disease, has been treated with Bevacizumab. Here is the typical regimen, 5 milligrams per kilogram every 2 weeks for 4 cycles. And then this nice article by Chamberlain and colleagues from Washington State. There's an enhancing lesion here and quite a lot of intramedullary signal abnormality, which is dramatically reduced with Bevacizumab. A problem for these patients is getting the drug financed. As we mentioned earlier, it's extremely effective and it's extremely expensive. It is not approved for these indications. Pseudo progression is another entity of which neurologists should be aware, and it's becoming an increasing problem in the era of temozolomide treatment with radiation. You'll hear more about this in the primary tumor section, but I wanted to emphasize it here because it certainly occurs with cerebral metastases as well. Here is a patient who has completed his radiation therapy and has a residual ring-enhancing lesion in the left thalamus. And here he is at a time of increasing thalamic pain some 8 weeks later. Is this recurrence, is it pseudo progression? About half of these patients will be better a few weeks later. So the answer is to watch and wait, put the patient on steroids, and re-image at a short interval. Another problem of which neurologists should be aware is cavernous angioma. These are induced by radiation. They can be thought of as a biomarker for the severity of the radiation injury, and often they're quiescent, as here in a patient who had a medulloblastoma, thus the large fourth ventricle. There are multiple hypointensities on these T2 weighted and susceptibility images. There are a great number of them. Are they just going to sit there, or do they cause something? Let's look at the lower right-hand corner. Here's a patient who has a ring of hypointensity around his brainstem. This patient has the triad of superficial siderosis, myelopathy, ataxia, and hearing loss years out from his radiation therapy. It's thought that there are multiple microbleeds and that hemosiderin deposits in the glial sheath, particularly in the posterior fossa, in the interstices of the folia, and around the eighth nerve, giving rise to these clinical symptoms. Sadly, and as perhaps a wave of what's to come, we've begun to see some spinal complications from patients who received craniospinal radiation as well. And here we have a hemorrhage in the thoracic level in a patient who had received craniospinal radiation and who was devastated by this spinal complication. Finally, in this group of people, there's another syndrome that I think probably everybody listening to this may have seen at some time, but maybe didn't recognize it until he began to see it in a couple of patients who had posterior fossa radiation for medulloblastoma. And there's a strikingly similar sequence: stroke like migraine after radiation therapy. We think this is due to late radiation toxicity. Initially, we thought to just the posterior fossa, rendering this area more susceptible to cortical spreading depression. And here's a patient who's many years out from a medulloblastoma who is in one of these cycles. He's having a severe headache, severe hemi-neglect, left-sided weakness, and left sensory deficit. And as you can see, he has enhancement, not in a vascular distribution. This lasted for 11 days, during which time he had an FDG PET scan at symptom presentation showing marked hyperactivity in this area with residual hypoactivity after he improved. We tried all sorts of things, including anti-epileptic drugs and steroids. None seemed to make a big difference, and patients all seemed to recover. So initially it was thought to be something that you watch and wait, and it's going to have a pretty good outcome. And then the spectrum began to expand. It was not just peanut tumors and posterior fossa location. It was not all it was reversible, as we'll see from the patient on the right. It occurred right after surgery in a few case reports, and sadly it was not so benign. In the pediatric population, it was reported by Kranick and all from Children's Hospital in Philadelphia that the presence of recurring headaches was possibly a warning, a harbinger, a biomarker for stroke and other sequelae, and that these patients were going to be more at risk than their cohort for developing vascular complications of radiation therapy late after treatment. And finally, there was a variant that began to appear in adults only a couple of years ago, and it also has a rather clever acronym: acute late onset encephalopathy after radiation therapy, or the ALERT syndrome. Most of these patients have small vessel ischemic disease, but they don't have vasculitis, and they don't have, quote unquote, just radiation-related changes. They have these very odd, as you can see in the right here, gyral swellings that are not in a particular distribution. This patient was several years out from lung cancer. He was 8 years out, and let's look at him in the next picture here. He had treatment of small cell lung cancer that included prophylactic cranial radiation, so he never had known metastases. His EEG, like all of the SMART syndrome patients, shows very low voltage in the affected hemisphere. There can be this diffuse leptomeningeal enhancement. Again, you see the gyral swelling here. It's looking a little better here. It was not recognized, and this patient had a biopsy which was nonspecific. Really didn't show anything. It was, unfortunately, a procedure that he didn't need, and your patient shouldn't have if you recognize the SMART and ALERT syndromes. We thought this was a relatively benign entity until it became clear that many of these patients had other issues as well. So here is a patient who's had recurring episodes many years out from a primary tumor. Her original tumor was over here on the right. And here she is the day that she came in after about the 10th of these with a prolonged headache. Each of the others had been a hemiparesis with not much headache, but on this diffusion-weighted image you can see, with its accompanying ADC image, that she's having a large stroke. It was in an important area and rendered her hemiplegic. On the gradient echo, you can also see that she has many microbleeds. In the stroke literature, the presence of multiple microbleeds has recently been reported to be a risk factor for TIAs going on to stroke, or for stroke and recurrent stroke. And so if we look at these patients, all of them have these little areas of microbleeds. So you can imagine that their stroke recurrence risk is going to be very high, and one should make the differential between TIAs and alert syndrome, sometimes very difficult to do. Do cerebral microbleeds cause acute strokes has been another theme in the stroke literature. And let's look at this 69-year-old with non-small cell lung cancer who has received chemotherapy that has included bevacizumab. So that was in the summer of 2013. On susceptibility-weighted images in follow-up in August 2013, you can see that this patient has multiple areas of microbleeds, of hypointensity. So he's an older person with hypertension. And unfortunately, we don't know whether he had some of these before he got his bevacizumab. By October of 2013, however, at a time when he was doing not so badly, it was clear that he was having a few more. And by February 2014, a few weeks after the onset of cognitive dysfunction, he developed ataxia. It began abruptly, escalated to really inability to walk by March of 2014, and what we called cerebellar mutism over several weeks, from which he did not recover. So I think we're going to be seeing more of these patients who've received some of these anti-angiogenic agents, who've had cerebral microbleeds, who've received radiation therapy, and who've had long enough survival to develop some novel patterns of toxicity. Let's move to chemotherapy complications. I suppose you consider this slide a board slide. It has on it all the complications of the commonly used drugs. Vincristine neuropathy, well known. L-asparaginase, venous sinus thrombosis. This is a drug used mostly in acute lymphoblastic leukemia. Cytarabine, I alluded to, as cerebellar syndrome, as well as the lymphocytic meningitis when it's given intrathecally, prophylaxis with dexamethasone. Mitoxantrone, no longer in favor for use in multiple sclerosis, produces a dose-related cardiomyopathy and a non-dose-related promyelocytic leukemia. Capecitabine, increasingly used for patients with breast cancer, can produce a multifocal leukoencephalopathy. Since it is also used for patients with cerebral metastases, this is a clinical and radiographic distinction that you may be asked to make. Iphosphamide is probably the most dramatic, acutely toxic chemotherapy agent. It's in use for renal and ovarian cancer and a few other indications. An acute encephalopathy, sometimes during the infusion and sometimes progressing to status epilepticus and coma. The specific antidote for it is methylene blue. DMSO has been reported to cause stroke and indeed myocardial infarction as an agent used in stem cell transplants. Tacrolimus, cyclosporin, and sirolimus used in transplant patients have produced a whole panoply of complications. I'm going to dwell on tacrolimus in a moment. And again, the newer tyrosine kinase inhibitors that I alluded to earlier have been associated with PRES and pseudo progression. Let's look at one of the really important peripheral neuropathic complications of chemotherapy. This is the dose-limiting and certainly quality-of-life-limiting toxicity for many patients who received the old drugs, quote-unquote, like vincristine, platinum, and the taxanes. These drugs can coast, and by that we mean the patient can get worse weeks to months after he's finished his chemotherapy. A few other toxicities of which you should be aware. Oxaliplatin produces a chronic delayed axonal or neuronal sensory toxicity, and it can also produce a very dramatic acute syndrome in which patients have cold-induced pain. This goes away very quickly. Paclitaxel can produce an acute pain syndrome that occurs a few days after the dose. Bortezomib, a very valuable proteasome inhibitor used in multiple myeloma, produces a reversible neuropathy that peaks at around 3 to 4 months. Thalidomide can have a sensory and autonomic neuropathy. Lenalidomide is better. The thalidomide neuropathy, unfortunately, is often irreversible. Abraxane, a solvent-free albumin-bound paclitaxel, can produce a sensory motor, and we've seen a rather dramatic motor neuropathy as well occurring during this coasting period. The other drugs that can produce this are listed here, and all of them are capable of both central and peripheral neuropathic complications. There are, unfortunately, no great neuropathic pain strategies. The usual drugs, gabapentin, duloxetine, and pregabalin, are all tried by us. We tried topical baclofen, ketamine, and amitriptyline, available as a combination. Sometimes the patient expresses his neuropathy as a restless leg syndrome. Certainly some of these patients will have reason to be iron deficient, so check an iron level. And recently, one of my patients suggested that when she'd been in the hospital, she'd been given pneumatic boots to prevent venous thromboembolism, and miraculously, her restless leg syndrome went away. She prevailed upon me to get pneumatic boots for her at home. She wears them an hour at night before she goes to bed and has had dramatic relief, so a suggestion that I extend to you. Failed prevention attempts include all of the things listed in the slide, including calcium and magnesium salts during platinum infusion, oxcarbazepine, and glutathione. Retinoic acid and vitamin E have had their day, and it's gone, and venlafaxine has been used. Again, these are isolated reports, or at best very small series, not holding up. It's important to emphasize one particular drug's toxicity, and that's methotrexate. Let's look at some of the common things. Above is the leukoencephalopathy that can occur after high-dose intravenous methotrexate, particularly when the patient also receives radiation therapy. On the upper left is a patient who presented with a dementing disorder after having an Ommaya reservoir placed for treatment of his leukemia. We were asked to see him because he was thought to have possibly progressive multifocal leukoencephalopathy. 2 months later, his white matter abnormality looked worse, but look at the pattern. It's around his reservoir. The reservoir was removed 3 months after symptom onset, and while some of the symptoms regressed, as you can see on the right, he was left with a fair amount of cognitive difficulty. This patient had also received rituximab. I don't think it was possible that it was responsible for the toxicity, but it could have been included in a discussion about PML. Probably the most important one to think about is whether the patient has had a stroke and whether that person can have a stroke, can have the drug again. This is a patient, this is a little more common in children, but this happens to be an adult patient. 3 to 15 days after intravenous or intrathecal methotrexate. Methotrexate toxicity-related focal deficits can be an important mime of ischemic stroke. Here's a patient with DWI and ADC after a stroke-like episode involving her arm and face 7 days after her 10th dose of intrathecal therapy. It resolved, and she was able to receive the drug again. Very occasionally, there's an acute myelopathy with intrathecal therapy and acute cerebral toxicity with high-dose intravenous or intrathecal therapy. Other chemotherapeutic toxicities. I repeated the Ommaya reservoir just because it's a striking thing to look for. That reservoir was probably leaking. Other specific things are metronidazole toxicity. This patient has myeloma, and he presented with ataxia. It's very specifically in the dentate nuclei, and when you see this MRI picture, you should think of metronidazole toxicity. Capecitabine can produce this area of signal abnormality in the splenium and anterior corpus callosum, so it's one of the causes of splenial lesions. And this patient, on the lower right-hand corner, had conventional 5-fluorouracil for colon cancer. She has, as you can see, a dramatic leukoencephalopathy. The reason for which is that despite the conventional dosing, she has dihydropyrimidine dehydrogenase deficiency. This is not routinely screened for, but should you see a patient who has incipient white matter disease or any of these other things that we're seeing here on the diffusion image in the splenium, on the flare image in the splenium, in the posterior fossa in the brainstem and diffusely around the ventricles. I would raise the question of screening for this and for whether the patient ought to have very different dosing for this necessary drug. Among the newer toxicities from the cytotoxic immunomodulator and targeted drug therapy, again, pseudo progression on temozolomide. I emphasize it again. Liposomal cytarabine, the meningitis. Selumetinib, a MEK1/2 inhibitor, produces some focal myositis with dramatic reports of a dropped head syndrome in some patients. And again, never can emphasize enough the anti-angiogenic agents, hypertension and PRES. These are some of the various types of pictures that one can see with reversible posterior leukoencephalopathy syndrome or posterior reversal encephalopathy syndrome, whichever acronym you prefer. Clinically, it's a variable mix of seizures, headache, hypertension, altered sensorium, and visual problems. Here, bevacizumab in a patient with colon cancer. This is the most classic. Here, tacrolimus-associated PRES in a patient who has received the drug for AML, tacrolimus. This patient received 1 dose of gemcitabine for breast cancer. Here, it's neither posterior nor loco, nor particularly reversible, so it's not a great acronym, but that's the one we have to work with. This patient doesn't have cancer, but has the most dramatic PRES that I've seen. He had sickle cell in crisis and some hypertension. And here's a patient who received radiation therapy, has classic PRES here, and not so classic PRES frontally, but also in the spinal cord. So keep this in mind. The current debate for patients who've had seizures during a PRES episode is how long they should be treated with whatever anti-epileptic drug you choose. The most frequently chosen drug is levetiracetam, and the duration of treatment is really not clear for most of these patients. We try to take them off within a month. PRES can be complicated by vasculopathy. Here, a 62-year-old man who received sunitinib. He has hypertensive crisis, he's thrombocytopenic, and he has schistocytes. So he has PRES plus vasculopathy. At presentation, he had posterior fossa PRES. His ADC image was okay, but 8 days later, after the PRES had cleared, he had a stroke in the left posterior cerebral territory documented by DWI and ADC images. Getting on to tacrolimus toxicity, this is a busy slide because there are innumerable complications of tacrolimus. We've mentioned the first 4. The 5th, tumefactive MS, can be seen in some patients as reported here. This will respond to withdrawal of the drug and often requires some steroids. Chronic inflammatory demyelinating polyneuropathy and brachial plexopathy have been reported. Pseudotumor cerebri in some patients, and a very dramatic akinetic mutism, which often goes on for a couple of weeks because no one has thought of it. The levels do not have to be elevated for the patient to develop this. There are no clear-cut specific predisposing factors, but you need to think of it and get rid of the drug. Central pontine myelinolysis has been reported as well. Hearing loss, and here a case that we reported of bilateral optic neuropathy, unfortunately, a patient who also had a little white matter disease. There are important drug interactions with tacrolimus. It's metabolized by P450 enzymes. You should put patients on non-enzyme-inducing anti-epileptic drugs. The new oral anticoagulants interfere with P-glycoprotein, and they can lead to increased TAC levels. So if your patient requires anticoagulation, it's something really to think about. And patients who develop C. diff can have trouble with elimination, and tacrolimus levels can go up. Here's something never to miss. This is part of a case series from N.D. Anderson in which only this patient was diagnosed pre-mortem. So it's a great service to the cancer community to report these patients. She's 65 years old with uterine leiomyosarcoma. She's had multiple procedures and has had a very large weight loss during this period. She's been treated with 2 doses of iphosphamide and doxorubicin with transient confusion of the type that's been reported with iphosphamide. Over the next 2 weeks, however, she develops fluctuating disorientation, tremor, blurred vision, and stupor. And while one would think that maybe this is the iphosphamide, what else has happened to this lady during treatment? She's lost a lot of weight. She's been eating poorly. Check a thiamine level. This is Wernicke's encephalopathy. The patient could have perhaps lost her anterograde memory. This was recognized. The patient was treated in time. It's not just alcoholics. It's our poorly nourished, nauseated, weight loss, oncologic population in whom you have to think of this as well. So here's a case of encephalopathy without any cancer therapy, but with an indolent small cell systemic lymphoma. Patient presents with some numbness of her face and a little facial weakness and then some ataxia, progressing from here over a very short period of weeks to this much more dramatic flare image. And as you can imagine from the lower right-hand corner, this patient rapidly became locked in. What's this disease? This is progressive multifocal leukoencephalopathy. Why does she have it? She hasn't been treated with any immunosuppression, but by virtue of her disease itself, she likely is immunosuppressed. And if you're thinking, well, end of this lecture, I'm not going to be an oncologist and I'm not going to have to deal with these drugs, you are going to have to deal with these populations. I make a longer list every year of these quote-unquote therapeutic poisons that can produce CNS infections or something that mimics it and greatly increase the risk for the groups of patients listed below here. HIV patients, organ transplant recipients, multiple types of hematologic malignancies, GI, Crohn's, ulcerative colitis, the rheumatologic disorders, sarcoid, psoriasis for dermatologists, myasthenia, uveitis, MS and neuromyelitis optica, polymyositis, and myelofibrosis. The list goes on and on. One has to worry about infection in a lot of these patients. They can have certainly groups are overrepresented here. 25% of all CNS infections occur in the leukemia lymphoma population, and brain tumor patients represent 16% of CNS infections. Neurosurgical patients account for 3/4 of bacterial and fungal meningitis, and toxo occurs largely in the hematopoietic cell transplant group. The types of immune deficits and the associated organisms are listed there. Let's go through some of them. This is from a very large Memorial Sloan Kettering series that remains the most up-to-date look at this population. 80% of patients with bacterial and fungal infections have had prior neurosurgery. Organisms are nearly always 70% gram-positive cocci. There are fewer listeria and strep pneumo. So these are patients with meningitis. 5% have the classic meningeal triad. That's not very many, so you have to think of other presentations. Shunt infections can present, in fact, with just mental status changes, and 1/3 of neutropenic patients with meningitis have normal spinal fluid. So even those parameters don't hold up very well. So the evolving spectrum of meningitis in these patients is extremely complicated. Use DWI, diffusion-weighted imaging, is great for detecting restricted diffusion in the setting of pyogenic meningitis, here post-operative and here deep in the thalamus. There are new patterns of infections. They can occur much earlier than you would think. I remember seeing this patient thinking she can't possibly have PML after only 3 doses of CHOP with rituximab, but remember what her disease is. It's systemic non-Hodgkin lymphoma, and she developed rapid evolution of posterior fossa and bitemporal disease. This is a patient who's received brentuximab, another closely related drug. So keep your ears open for the evolving spectrum of PML-associated drugs. This is an antibody-drug conjugate linking the antimicrotubule agent monomethyl auristatin to a CD30 monoclonal antibody that's frequently expressed on anaplastic large cell lymphoma as well as in Hodgkin's lymphoma. And this patient developed PML after only 2 courses of this drug. The distribution here makes it look a little bit like PML, but a little bit like PRESS, but it's PML. Immune reconstitution can occur in this population as well. You're very familiar with this in the HIV population, but think of patients who are getting treated for their cancer gets better, their immune system revs up, they have some residual infectious antigen, and they can have worsening of clinical or radiographic manifestations. The symptoms can occur during receipt of appropriate therapy, and they can't be explained by a new infection. There are negative culture results. Here are some examples. Cryptococcal immune reconstitution following alemtuzumab for lymphoma, chronic disseminated candidiasis after neutrophil recovery, TB-related iris after stopping infliximab, CMV-related retinitis, iris occurs in almost 5% of solid organ transplant patients who've had cryptococcus. A relapsing, remitting MS-like illness or chronic graft versus host disease can all represent forms of immune reconstitution in the cancer population. Other well-known infections will present with atypical manifestations in immune-compromised patients. This is a patient series looking at HSV-1 encephalitis. 3 out of 4 had acellular CSF, and there weren't very many prodromal symptoms. There was widespread cortical involvement, not just the temporal lobes. There's recurrence in 1 out of 7. Mortality was 6 times that of immunocompetent patients. So use acyclovir while you think about the situation. The patient has any encephalitic complications. And look at the section B also. Here's another presentation that's specific to the cancer population. Here's a patient receiving cranial radiation for lymphoma, as seen on the left. She develops a new allergic reaction to phenytoin, begins to have seizures, and now has a contralateral signal abnormality that was thought at first just to be seizures, but when the seizures stopped, it actually got worse. This turns out to be HSV reactivation during radiation therapy and during an episode of drug rash with eosinophilia or DRESS. HSV encephalitis patients who relapse or who fail to get better may have uncovered other antibodies. The NMDA receptor antibody has appeared in a number of patients who are described in the case series and individual case reports that I have on this slide. So if your patients are having an atypical course or relapsing HSV symptoms or have persistent movement disorders, it's worthwhile checking NMDA receptors both in serum and CSF. We now move on to the medical management of patients on the Cancer Consult Service, strategies to improve the quality of life during the acute treatment and in long-term survivors. We'll talk about seizures, steroids, venous thromboembolism, and we'll end with what I think is not a downer way to end this whole section, but rather a very upbeat way of beginning to palliate symptoms from the very beginning and changing the mindset about what palliative care in this group of patients really means. Seizure epidemiology. Up to 70% of brain tumor patients may have seizures. Most occur pre-treatment, but a third will have recurrent seizures and some will have refractory seizures. Location counts, cortical, greater than deep or infratentorial. Histology counts, and in fact, the focus of our talk today includes the group of people who have perhaps the least likelihood of seizures. It's the low-grade glial tumors that have the highest risk. American Academy of Neurology practice parameter dates to the year 2000, which in neurology is a pretty long time, 15 years. Prophylactic administration of anticonvulsant medications does not provide substantial benefit, and therefore Academy members have been admonished not to start seizure medicines unless the patient has a seizure to begin with. That was echoed also by a neurosurgical group, and that's not what we're doing. 89% of our glioma patients get anti-epileptic drug therapy, though fewer than a third present with seizures. So what's the parameter rationale? The rationale was that there was really no benefit from these older drugs. These are the ones that were included in that 15-year-old study. 42% had subtherapeutic levels, and the general considerations were that there were lots of adverse effects that were problematic, that could cause reduction in efficacy of chemotherapy drugs. It could cause horrible Stevens-Johnson reactions or confuse with metastases when lesions like this on vigabatrin developed. Psychosis can develop on levetiracetam. There's weight gain on almost all the drugs and cognitive issues on all of them except lamotrigine. So, should we be adhering to this parameter in the era of new drugs? We surely should be careful about using enzyme-inducing anti-epileptic drugs with virtually all the categories of chemotherapy agents listed there. Note, not temozolomide, the drug most frequently used for primary tumors. Are there exceptions to the AAN parameter? And I would argue that this patient, whom we've seen before with multiple cortically based hemorrhagic melanoma lesions, should be on prophylactic therapy. These are people with limited life expectancy who we do not want to see coming back into the hospital. The 3-month seizure rate in this study from Goldlist and colleagues was 17% without and 0 with anti-epileptic drugs. The available non-enzyme-inducing drugs that I think are probably best considered here are circled here. Lamotrigine's downside is it takes a long time to load up on it. Lacosamide and levetiracetam are probably the drugs of choice at this point. Drugs with increased toxicity on valproate, an enzyme inhibitor, are listed there, and we should all warn our oncologic colleagues about those. Levetiracetam has minimal sedation, can be loaded up quickly. It's been available in an intravenous preparation for the last 9 years, but many of these patients have a behavioral alteration. They need to be warned about that. Increasingly, lacosamide is being used. When there are more seizures, consider the obvious, more tumor or a secondary tumor. Leptomeningeal disease. Don't forget about venous thrombosis presenting with focal deficits and seizures. The other possibilities are listed there, and the not-so-obvious things. Non-convulsive status epilepticus, PRESS, the oncologic drugs listed there, the autoimmune encephalitides, we just alluded to NMDA receptor encephalitis, and late sequelae of therapy. Every one of us has dealt with complications of corticosteroids. On the left, bolded in yellow, are the important ones: myopathy, weight gain and edema, behavioral change, insomnia, and diabetes, which sometimes doesn't go away after the corticosteroids are reduced or eliminated. Uncommon, in fact, is gastric irritation, except in the very highest doses, and patients who need to be on corticosteroids for more than 2 months ought to be on pneumocystis jirovecii prophylaxis. Those who develop osteoporosis should be considered for vertebroplasty, which can be really symptom-changing, a very dramatic improvement in quality of life. All of us should remind our oncologic colleagues to keep up the vitamin D and calcium. Everyone has a favored withdrawal regimen, but there is marked inter-individual variability in the hypothalamic pituitary axis, and some of our patients develop adrenal insufficiency. The symptoms aren't very obvious. The patients may have fatigue, somnolence. They may just call you up and say, "I feel bad." And you have to go back and look and say, when did I stop the corticosteroids? Check an 8 a.m. cortisol and repeat and replete. That can be a very great boon to your patient's bill of health, as can the recognition of potentially fatal causes of shortness of breath in brain tumor patients. Pneumocystis jirovecii pneumonia, mentioned, has a 40% case mortality. We render many of our patients profoundly lymphopenic. They need to be on prophylaxis with trimethoprim, sulfamethoxazole 3 times a week. Those who are on corticosteroids in doses in excess of 1 to 2 milligrams per day of dexamethasone also need to be. Another cause of shortness of breath is venous thromboembolism with pulmonary emboli. High-grade gliomas have the highest risk. Cancer-related venous thromboembolism appears to be better treated with heparinoids if the patient can have it covered by his insurance than with warfarin. It's just simply easier with fewer interactions. Multimodality preventive approach is listed there, again, those pneumatic boots. And the evolving role of the oral agents remains very unclear. I'm asked this about once a week. We just don't have enough information in our cancer patients to recommend the use of dabigatran, rivaroxaban, or apixaban in this group of people. We do have a good algorithm for treatment of venous thromboembolism in brain tumor patients, and this includes getting a diagnosis with a Doppler and a CT of the chest. If there's been a craniotomy within 1 week, or there's a high-risk tumor histology or an obvious bleed, then there's an anticoagulation contraindication there, as well as impending surgery, liver disease, or cytopenias. If that's present, an intravenous filter, which has a high complication rate in this group, an inferior vena cava filter, can be used. If not, get a non-contrast head CT. If there's no acute blood, the patient can receive heparin. If they are not intolerant of heparin, then they have lifelong anticoagulation, preferably with a low molecular weight heparinoid. And then we have our long-term survivors. 35 years after allogeneic transplant, this young woman is seen. She had ALL at age 9. She received TBI. She had breast cancer some years after that. She had basal cell carcinoma of the scalp. BMI was 30. She presented with a high-grade meningioma. This was resected, irradiated again, has another meningioma, a third meningioma, has a DVT, has to have a filter placed. Craniotomy is complicated by a pulmonary embolus and a wound infection, and she spends 5 months in the hospital with rehabilitation. She then has a cerebral hemorrhage on enoxaparin, followed by the development of another operation, and finally the development of new growth in the cavernous sinus, at which point she elected not to have any further therapy. Now, this doesn't happen to all of our patients, but we have a growing population of people who have secondary cancers and vascular disease from these prior treatments. There are 26,000 adolescents and young adults diagnosed with invasive cancer annually. Their survival rate is remarkably wonderful. But 25 years after the first cancer diagnosis, the death rate due to subsequent malignancy exceeds all other causes. It's not just meningiomas, it's secondary glial tumors. 22% of ALL patients who are treated aged 1 to 8 are going to have radiation-induced meningiomas. They can be multiple, atypical. Sometimes radiosurgery can control them, but sometimes not, as in the patient we just presented, and other tumors can develop as well. This is a young man who's 34 years out from a craniopharyngioma and now has a glioblastoma. Try not to irradiate patients at any stage. Cerebrovascular disease is becoming an increasing concern. Dr. Patrick Wen has supplied this interesting angiogram, which shows unusual vascular disease at multiple levels seen in patients who've had radiation therapy. There are now many, many survivors of childhood cancer, 1 in 640 adults between the ages of 20 and 39. The current 5-year survival for childhood brain tumors is over 70%. The risk for stroke is increased in CNS tumors, Hodgkin's lymphoma, and leukemia patients who received radiation to these areas. It can be both large and small vessel disease. It can produce a moya-moya-like picture. It can produce a mineralizing angiopathy deep in the basal ganglia with movement disorders, pseudoaneurysms, vascular Parkinsonism, and these cerebral microbleeds. So it's another whole evolving area. When your patient with cancer has a stroke, what kind of differential diagnosis do you have? It's very different from other patients. Here's a 66-year-old man, hematopoietic cell transfer, AML. 5 months later, he develops altered mental status. He has infarcts that are old, of varying ages in his posterior fossa and supratentorially, but these are all DWI positive. And here's your differential, which has very different treatment. Is it emboli? Does he have disseminated intravascular coagulation or non-bacterial thrombotic endocarditis? Does he have zoster? Does he have intravenous lymphoma now? He should be treated with rituximab. Does he have graft versus host disease? So he has a spinal tap. He has 230 white cells. That excludes many of our considered diagnoses. It's probably not septic infarcts. It's probably not non-bacterial thrombotic endocarditis. It's not graft versus host disease. Could be intravascular lymphoma, that's still on the list, and it could be zoster. That would be much more treatable. What he needs is a CSF IgG for varicella zoster. He was treated for zoster successfully. And so laminate this slide, a checklist of physical problems of long-term brain tumor survivors. It's a shorter list for the anti-epileptic drugs and chemotherapy, and a hugely long list. You perhaps don't even need to look at all of the list. This comes from a wonderful article called Adult Primary Care After Childhood ALL, meaning that there are enough survivors that it's important for primary care doctors to know these complications. Just look at the picture. There are 2 identical twins at 26 years of age. The twin on the right was treated for ALL at age 5. The twin on the left was not. Clearly a difference in life complications. So I would end by saying that there is almost a developing new subspecialty area in neurology, cancer survivorship. In the past year, among my 4 dozen or so survivors of childhood cancer in our survivorship clinic, the following things have happened. New intractable seizures in one medulloblastoma patient, recurring seizures after stroke in an astrocytoma survivor, 1 death among the smart tumor patients from just slow debility and seizures, 1 death from a pontine stroke, the spinal cord bleed that you saw earlier from a cavernoma, headache and stroke in the alert patient that you saw, and now in the era of CART19 therapy, novel complications that looked initially like JC virus neuronopathy, but in fact led to really a wipeout of neurons throughout the brain. So we need to learn to control our therapies, to know what bad things they can produce, and continue to look for better care for our patients throughout the course. This is the old model of palliative care. Disease-directed therapies, and then at the very end of life, palliative care. This is from my colleague, Dr. Matthew Mencken, who brings the perspective of a palliative care neurologist to our department and has made huge contributions to the quality of patient care. And this is the current model, his current model, disease-directed therapies with palliative care throughout the whole period, not just at the end of life. Palliative care, in fact, can lead to longer survival, as this seminal article from the New England Journal a few years ago showed in solid tumor patients. Nevertheless, the median hospice stay in our area is an abysmal 16 days, in part because patients wish to continue therapy and cannot do so when they are when they're in hospice. We must keep in mind that we need to keep looking for better therapies for these patients. And I would end with Foster Kennedy, who described the Foster Kennedy syndrome. And probably many of the listeners have never seen that because it predates neuroimaging. It was papilledema on one side from raised intracranial pressure and optic atrophy on the other from the location of a tumor. We would probably never get that far in the era of MRI. But Foster Kennedy's words are timeless. He who cares for patients suffering from brain tumor must bring to his problem much thought and stout action. There is need also of a formidable optimism, for the dice of the gods are loaded. Thanks for your attention.